The future of talk is here. Power 102 Digital.
It is Power 102 Digital Wednesday. It's time for Hard Talk with the topic diabetes and kidney disorder. Our host for today is Fareed Ali, and Hard Talk starts now. Good afternoon, Fareed.
Good afternoon, David. It's good to hear your voice. How are you?
I'm doing fine.
To the listening public, what we're doing this week is we're continuing this series of a discussion on diabetes and a discussion on some of the effects of diabetes and what others have to contend with who carry the disease. Today we have no other than another specialist, highly trained professional, Dr. Sean Lynch. He is a specialist in internal medicine, nephrology and kidney transplant. Dr. Lynch completed his medical school at the University of the West Indies and his internal medicine specialty training in Trinidad and Tobago before completing his general nephrology and kidney transplant fellowships at the University of Toronto, Canada. So Dr. Lynch is online with us. He is soon to join us as soon as we make contact with him by him putting on his camera and so on. Dr. Lynch, good afternoon. It's good to see you.
Good afternoon.
Good afternoon. It's such a pleasure to have you with us this afternoon. Like I had said to you off air, we've been doing a series on the non-communicable disease, diabetes, and we've had some discussions with other doctors in the past few weeks with different specializations. So today, what you're bringing to the table for the public is basically your expertise and your training, some of the experiences that you would have had in terms of treating persons who would have been suffering from the I would imagine, the medium to long-term effects of mismanaging the condition, so much so that they experiencing kidney dysfunction and issues that arise with the effect uncontrolled, well, not controlling their diabetes could have on their kidneys. I want to thank you for taking the time because I know that you would have a busy schedule, and to spend time with us this afternoon is an effort that we appreciate. Thank you so much.
Pleasure is mine. I always look forward to these educational programs. Quite frankly, I think we need to do more of them.
So tell me something, based on the readings that I have done, and I'm a lay person here, are you of the view that the non-communicable disease, diabetes, can be eradicated, or it's something that, and when I say eradicated, from the literature I've been reading, it is suggested that we've passed the stage where we should be making attempts to prevent diabetes. We should try to eradicate it altogether in terms of the choices that we make and how we approach managing the condition. Are you of the view that this is a realistic goal and objective?
Very difficult because, these are lifestyle diseases, essentially. Lifestyle diseases require people to change the way they do things, and that's very difficult to change human behavior. It's probably easier for someone to take a pill than to actually change their behavior. But it has to be done because we are literally killing ourselves by embarking on behavior that over the long term is detrimental to our health. And the diseases are fully preventable with lifestyle modification and change.
But human beings are creatures of habits, and like you said, it's difficult to break habits that would have been established over a course of time. The temptation is always there. I was saying to a previous guest, and in my simple observation, when doctors like yourself encourage people to eat in a particular way and to watch their calorie intake, watch their sugar intake, be mindful of eating processed foods, be mindful of the consistency that one would eat processed foods. It's difficult. It's a difficult regime to follow if it is you're eating outside of your home. Because when you go to buy food around the savannah in Port of Spain, or you go to a food court, if you go to KFC, Subway, everything involves using condiments, we are sources people are trying to be. Everybody like how things taste, but what goes into the taste is it's condiments, it's processed ingredients. So are you of the view that in the fight to prevent, control, eradicate such a condition, the diabetes and its effects, that there needs to be more, there may be the need for more government controlled regulations which put the fast food industry and the food industry in a position where they have to follow strict regulations and guidelines in putting products on in the public space?
Well, that's always a controversial question, and that's getting into the political realm and stuff. I mean, the issue with food and diet and health is multifactorial. I mean, as with most things, having fast food occasionally is not really an issue. The problem becomes when it becomes habitual. But more importantly, rather than regulating the fast food industry, I think one of the ways that will be far more effective, but obviously will take a longer time to see fruition, is start with the kids. So for instance, I see my kids do things that I didn't. We always, when I was growing up, we had to have juice or sweet drink or that kind of thing. My kids drink water, and that came solely from their school. And the sort of habits that they inculcated there. This is a very, very difficult topic, very difficult question. But people also have to take individual responsibility for themselves as well. No one is forcing people to do anything. And people have to recognize the deleterious effects of poor diet. And who's to say that fast food is any worse than what is being cooked in some Trinidadian homes? I mean, some of the food that we call our staple dishes are not healthy. So it's for me, it's more about changing choice rather than trying to force change on people. I mean, they must accept it themselves, because we could stop fast food and people going to fry their chicken at home and do the same bad behaviors at home as well, and we certainly can't stop that.
But some of the data that in the public space, I was reading that according to the Diabetes Federation's Diabetes Atlas 9th edition, it says that 428 million people, if I may put it this way, suffer with the condition or have diabetes. And another, that's worldwide, that is. And another 200 million may have it and be unaware.
Yes.
If we look locally, some of the data out there is that there are 180,000 people with diabetes in Trinidad and Tobago, and another 60 to 80,000 people who may have it and not even know. So what are your suggestions in terms of the public? I would imagine the first call would be to diagnosis. I guess we should all have ourselves check our blood sugar levels, ensure that it is where it's supposed to be in terms of the calibration levels, and then take it from there in the context of approach diet and approach exercise. That's at least the basic starting.
Well, I always say this. I've said this numerous times. Folk take their cars to service. They carry it to the mechanic. They get a tune-up. They change the oil. They check it out. But yet, people take some sort of bravado. Patients will tell me, "Oh, I've never been to a doctor in the past 10 years." Now, for me, I don't see that as being anything to be too proud about. Why? Because a lot of diseases, a lot of cancers and stuff right now, they don't have symptoms. So diabetes, yes, if some people may have symptoms, they may feel very thirsty, they may be losing weight, they're feeling hungry all the time, but the vast majority may have no symptoms, or we put off and we attribute some of those symptoms to other things. You know, you're getting tired, your kid's giving you stress, that sort of thing. So in disease processes where there are very little symptoms, then the next best way to pick it up, and to pick it up at an early stage, is to screen, where we actually look for it prospectively. We are actually looking to try and pick this thing up. So, you know, it's very simple. You know, after you reach a certain age, you should be, especially if you have a family history, you should be screening for diabetes. And it's a simple test. We now use a A1C test as a screening tool. And I always say I don't see anything wrong when a patient going to a doctor. It doesn't have to be a specialist. They can go to their local doctor, their family physician, and getting the same tune-up that you take your car for. You know, getting a physical exam, taking a bit of a history, doing some routine blood work. Because if we start picking up things at an earlier stage, it allows us to act and to prevent some of the complications from the disease.
Well, I'm hoping that through this program and some of the others that we had, that awareness that we are creating, and like you said, the same way we treat our material possessions with care, that we should treat ourselves with more care and equal to, at least. So the regular checkups will always be a benefit. So tell me something, in your experience as a practicing physician, and I know from my conversation with you, you work both in the public and private sector. What are some of the experiences you would have had? And I know there's doctor-patient confidentiality. I'm talking about what are some of the general observations that you may have with persons who are already diagnosed as diabetic? And apart from general observations, how does one, and I'm getting into your specialization, how does one transcend or make that journey from being diabetic and getting to the levels where we now have kidney problems or issues, kidney dysfunction?
So unfortunately, in my practice, the vast majority of patients, when diagnosed with diabetes, absolutely don't think anything is wrong with them. And that's part and parcel of the fact that most times they're not feeling unwell. So, you know, you tell them that and they smile, they don't take it on. They don't see it as a problem, because we have a societal sort of thing where we only think we are sick when we're actually feeling unwell. But what we don't understand is having these chronic diseases is slowly killing yourself over time. You're actually damaging your internal organs that you can't see or that you can't feel at that point in time. Most people actually only seek care when they're feeling unwell. And part of the problem with that is a lot of times when you start to feel unwell is when a lot of the damage has already established itself and becomes irreversible. So it's a whole societal sort of change in attitude towards diagnoses, where, and I see this not only with diabetes, but lots of other chronic diseases that have no symptoms, including kidney disease, where people need to understand that when you're told something at an early stage, that is the time to act. That is the time to make the change. That is the time to try and read around the subject and grasp it and make it part of you. Oftentimes what happens is people ignore it for years upon years. And then when they experience a bad complication, that's when they want to be the best patient. That's when they want to read and do everything. And a lot of times that's at the point where we've missed the boat. The horse has left the stable. The first thing really to do is to prevent diabetes from happening in the first place. And that encompasses lifestyle and exercise. We don't exercise enough as a society. We eat too much and we eat the wrong things. And as I said, for me, that's a generational sort of change that has to happen. But the second best thing is, if you are diagnosed, we pick it up early through screening. The third best thing is, we're diagnosed early, then we start managing it well. And that's a sort of paradigm shift that has to happen with the psyche of the country. because people wait far too late to start taking these disease processes seriously.
Wow. So what you're describing sounds like, when you have a leaking roof, people notice that there's a leak, but until the rafter boards and the sea purlins start being affected and the structure looks like it's about to crumble, then they look to fix the roof, change the roof, address the structure. It's almost like a leak in your foundation then. You're seeing cracks on the floor, but it's only when it's huge cracks you decide to address what is underneath there. I guess people like to, the mindset is you deal with a problem when it's unmanageable, and you're sufficiently uncomfortable that I can't do this anymore.
Yeah, that's often the case. Often too, people like to run away from quote unquote problems, especially male patients. The Trinidadian male patients like to run away from the problem, ignore it, hoping that it will never cause them an issue. And oftentimes it frequently comes back, and it does.
Let me ask a question here, Doc. You've been you guys have been talking about the diagnosis of diabetics.
Yes.
Is it the same for pre-diabetics?
Yes. So pre-diabetics, all it is the range of test results. So in diabetes, for instance, if your A1C is greater than 6.5%, we consider that a diagnosis of diabetes. Whereas pre-diabetic, between 5.8 and 6.5. Now, all it is just it's a continuum of risk. It's all on the same line. And what a pre-diabetic diagnosis really is saying is that, hey, listen, you have to take stock of things before you actually step into the range where you become diabetic.
Okay, thank you.
Wow. What is the cycle? And if this is a fair question, what is the life cycle in terms of being diagnosed diabetic, and this is for naturally the unmanaged diabetic condition? What is the time cycle for you to get to the level where your kidneys begins to be affected?
So that's an interesting question. So long ago we thought we knew this. And largely because of the study of type 1 diabetics. Now, type 1 diabetics, the reason why it's easier to study them is often they present at the time of diagnosis. In other words, when they are diagnosed, it's almost certainly that's where the disease process starts. Yeah. And there was some good data now, some good data from back in the day, where we didn't have all these fancy drugs and all these good management for diabetes and kidney disease with diabetes, where patients went from normal kidney function to spilling a little bit of protein in their urine, to spilling far more protein in their urine, to starting having kidney dysfunction in terms of the clearance of substances. And that process was about over a 15-year period. Now, the problem with type 2 diabetes is that a lot of people are walking around with it for years before they're diagnosed. So we actually don't know, in many cases, at which point the disease process starts. The second thing is often associated with other disease processes like high blood pressure, obesity, high lipids. So all those things act together to affect the kidney, whereas you can actually have people having kidney disease at the time of diagnosis of diabetes. They have already had established kidney disease because they've probably been walking around with diabetes for a number of years. So it's a bit more variable with the type 2 population, which is the vast majority of the population. Genetic factors obviously play a role in there as well. But if you look at older data with the type 1 population, you know, that's the sort of time span. So they'll go 15 to 20 years before you start to see reduction in the clearance of substances. Now, with that has changed significantly because of the vast improvement in management of these type 1 diabetic patients, where, you know, the other day I saw someone who is quite it was about 60 or something, and they have absolutely, and they would have been diagnosed when they were 15 or something like that. and I think they were 55, and they have absolutely no complications from it, which is amazing because we never would see this 25 years ago, 30 years ago.
That individual, in your conversation with them, is it that they had a regimen, or that they followed, or they attended to their condition very serious?
Yeah, they were just very tightly managed in terms of the change in diabetic management, in terms of insulin pumps. This is the latest thing where people have these pumps inserted that delivers insulin under the skin, that really really tightly control their blood sugar levels. In addition to some of the many medications that we may talk about later on that have come out that have helped these patients protect their kidneys and their hearts and this sort of thing. It's because of the advancements in science, essentially, with the improvement in how we deliver care.
Would it be safe for me to say that if you're diagnosed with a condition, then you need to be working with your physician at regular intervals, if not regularly, more regular than irregular intervals, in order to get assistance in managing the condition? Or is it something that somebody could self-cure at home, if I may use that expression?
Well, self-cure, again, that's the Trinidadian thing. You go, you see a patient, so you've been diabetic. Yes, how long? 20 years. Who's your doctor? Doc, I just manage my own thing. Immediately, that's a bad start, bad omen. It's not only about doctors, it's about the healthcare team. Dietitians play a very, very important role in the management of diabetes. With poor diet, it's very difficult for you to get anything under control. And to be quite fair, diet is probably the mainstay of management of diabetes. So it's a multidisciplinary approach, not only involving physicians like myself, but also involving the allied healthcare staff.
You mentioned earlier that there's this, and you could correct my language, you can have a insulin pump inserted, so when it is your body needs it, it regulates itself, that, so to speak, meaning that the insulin pump releases the insulin that you need.
Yeah, that's the latest way to manage type 1 diabetics, with insulin pumps. The endocrinologist would be really more familiar with the exact mechanisms and use of it, but essentially they have to test their sugars quite frequently, and they can adjust the dose of insulin that's delivered. It's expensive. It's expensive though.
That is where I'm going. I was about to ask you just that.
Well. Okay. So it's expensive, but it depends on how you count healthcare dollars. So, are you going to use a mechanism that is preventing someone from developing kidney failure and being on dialysis, from preventing heart disease, from preventing eye disease and going blind? Or are you going to spend the money later down the road to put them on dialysis or to have angiograms and to fix their hearts? And that's how first world countries view healthcare dollars, not as the cost of this now, but the cost of this now is helping me to save so much more down the line. And the studies are quite clear. So whereas it may seem prohibitively expensive, what's the cost of down the road when you develop the complications because you don't have the best possible care?
Well, I guess from what you're describing, it's a situation where you have to make a decision to live a quality life. And to have a quality life, you have to treat yourself well. And sometimes it may cost money in the short term, but the benefit will be medium to long term.
What's the cost of not being able to work because you have a complication from diabetes? So all these things are costs that people don't look at. They tend to look over. They look at the cost of a drug. So this drug is more expensive than this drug. Well, guess what? This drug is more expensive than this drug because it's going to prevent you from developing X, Y, and Z. And when you develop X, Y, and Z, you're going to spend money to treat that. You're probably going to get some bad complication. You're going to be off work or can't work. These are how healthcare dollars are checked. And that's how you look at whether something is of benefit to the patient and to society in general, because somebody has to pay for it, whether it's the government or the individual.
Give me your area of specialty. What is the value? And I know it may sound at first glance a silly question. What is the value of a kidney? What exactly? What does a kidney do that we all need it and we need to preserve its integrity?
Okay, so a kidney does many things. Major thing is it clears toxins from the body. So your cells produce energy, produce toxins as a waste product of metabolism. The kidney helps to get rid of it. The kidney helps to get rid of extra salt, extra water, extra electrolytes like potassium, which can be dangerous. The kidney is also an endocrine organ in that the kidney helps to build your blood count up by producing a hormone called erythropoietin. Also helps with the strength of your bones as well. In terms of it activates vitamin D that you would get from the sun or from food. It activates vitamin D to then develop strong bones. And also plays a role in the acid regulation of the body. So once you have kidney disease, you can have problems with any or all of those systems.
Wow. So with a malfunctioning kidney or kidney dysfunction on some level, you could be affected in all these areas that you've described.
Yeah. So dysfunction is a very broad term. We use the term chronic kidney disease, but even chronic kidney disease is a very broad distinction from people who may have, for lack of a better term, quote unquote, mild disease. They will have no symptoms and they will have none of those problems that I just cited. Even people with moderate disease wouldn't have any of those symptoms. You really start to develop most or all of those symptoms later on in the game. Later on, when you are close to needing something that we call dialysis, that you will develop all of the bad symptomatology of having little or no kidney function, which, as I said, is part of the problem, because early in the game or even at a moderate stage, people will be feeling well. I mean, I know I actually in my office right now, I would see patients and I would tell them, listen, this is what's going on. We really have to pay close attention to this. And I would see the look. And I know that guy thinks, I'm feeling good. Why is he telling me this? I have no problems, right? But I'm seeing the numbers in front of me and I'm seeing that this guy has a bad prognosis. This thing is probably going to get worse. And I know you could tell. And I'm like, that guy ain't come back to the office. And then invariably, 3-4 years down the line, I see my secretary book a name. I saw him 4 years ago, and I know exactly what has happened. And what has happened is that he's now sick, and his disease has progressed. And now he's sick and he's ill, and he wants to be treated. And unfortunately, a lot of times at that point, again, the horse has left the stable. So so chronic kidney disease is very broad. We usually will start to say you have chronic kidney disease when your kidney function is less than 60%. With 60 mils of GFR, you could think of it as percent. It's not quite that, but it's easier for people to picture it as a 60% or less. But even within that, if you have 50% kidney function, you're going to be perfectly fine. You're not going to have many problems. Even down to about 25-30%, most patients are okay. They're not going to feel exactly sick. It's really once you start to go below that you start to develop the symptoms, and then you get really bad when you reach between 5 and 10% or so.
Doc, you spoke about the kidney responsible for getting rid of toxins, and you mentioned potassium and that kind of thing. The people who tend to eat a lot of vegetables, some of the vegetation or vegetables, I should say, that people will consume will contain a lot of these
yes.
products, or what would you advise on people who eat a lot of vegetables or like a lot of bananas or a lot of
Continue. Absolutely continue. So a high potassium diet is actually very healthy and very beneficial. All that stuff lots of vegetables, bananas, all of that is very healthy. Now, if you have established kidney disease, then you have to look at the potassium in your diet. So for the general public, who most people wouldn't have kidney disease, all right? I mean, most people don't have kidney disease. So actually embarking on a high potassium diet is actually beneficial to both heart and kidney health. But if the kidneys become damaged from another process, let's say diabetes, for instance, as we're talking about, or some autoimmune disease, and you have significant kidney disease, then you have to limit your potassium intake. So it's only at that point, really, that you have to limit your potassium intake. Before that, if you have regular functioning kidneys, then a high potassium diet is actually good.
Okay, thank you. Fareed?
I've read where it is said that the skin is the largest organ in the body, and you tend to, a lot of what happens inside is reflected on the skin. Is there any relationship between chronic kidney disease, as you put it, and the manifestation of that on the skin? You know, I've heard so much.
So not necessarily. In the later stages of kidney disease, and I mean when people are really bad, down to need for dialysis, you can get a lot of itching. You get a lot of itching in the skin. You get a lot of dry skin. That's because of retention of phosphorus. That tends to happen when you have bad kidneys, and also the toxins tend to go under the skin and irritate, and you get itching. If you look at anybody who's had kidney disease for a long time, they tend to become darker, increase in pigmentation. And while we're not 100% sure why that happens, again, it's related to, it's believed to be the effect of the toxins on the skin. But apart from that, I wouldn't say there's any particular skin manifestations. There may be skin manifestations for certain diseases that may affect the kidney, but not per se. Once you have kidney disease, you'll have some sort of skin manifestation of the disease.
How many kidneys? I understand the human, we have two kidneys.
We have two.
So we can live without.
Well, most of us have two. Some of us may be born with one, and we can live safely with one functional kidney.
Why is there, and I hope we're not going off base here in terms of our core topic, but it's a curiosity that I have. Why is there such a huge problem in Trinidad and Tobago in terms of access to a kidney when you have renal failure? When there's no, your kidney stopped working, it stopped functioning, you need a kidney. Is there a particular reason why it is we can't access those things here? Why you get Trinidadians saying they're going and look for a kidney somewhere? That's the language. They're going to Turkey and they're going Pakistan. I understand it. You can't.
Well, that's very simple. I mean, there's my core thing. I mean, my training is in kidney transplant. A kidney doesn't grow on a tree, so you can't go in your backyard and pick a kidney like you will pick a mango. So if you need a kidney, you need someone to give it to you. You can get that in one or two ways. You can get a living donor transplant where you have a relative or a friend or somebody who admires you, and they come forward and they say, you know what, I would like to be a potential donor. And not because somebody comes forward, it means we take their kidney. They come forward and then we put them through a series of very, very, very rigorous tests to ensure that it's safe for us to take that kidney. So it's not anybody can just come and decide they're going to donate a kidney. You have to be very healthy. You have to have very good kidney function yourself, and we have to be assured that no harm comes to you should we take that kidney out. And that's what we call a living donor transplant, where someone will give up one of their kidneys to another. Well, guess what? We live in a very selfish society. So many people have problems getting someone who will be able to donate to them. Either one, we live in a very sick society as well. So a lot of people can't donate because they are themselves diabetic, or they themselves have kidney problems. Or they're not compatible in terms of blood group and these sort of things. So that's one thing. The other aspect is a deceased donor transplant. And a deceased donor transplant is where we get a kidney, and we at that time could get two of those kidneys. So a deceased donor will treat two patients from someone who's dead. All right. And based on the law in Trinidad, someone who's brain dead, they had a big stroke, and their brain stem, which is responsible for their breathing and all their higher and all their essential functions, has stopped working, and they're only being kept alive artificially by a ventilator and by things we do. So we do have the legislation for that in Trinidad, and we do have a transplant program, which up to recently we're doing deceased donor transplants. That requires, again, the permission of either the relative, most times of the person who is brain dead. And I can tell you from experience being around that, many times we don't get it. They simply don't want to give up the organs of their loved one for whatever reason. There's the idea that people think, oh, we have all these murders in Trinidad, why we can't just go and take their kidney? Well, it doesn't work like that. It's not like, oh, somebody dead, we shoot them and they're lying on the ground, and after we do whatever, we can go and take their kidney. That kidney wouldn't work. Remember, when they're dead, there's no blood perfusion to that kidney. All right. So they're lying there. If they get shot or what have you, there's no blood supplying that kidney will die. It doesn't work like that. So we do what you call controlled deceased donations, where the patient has to be brain dead. The organs are functioning, but their brain is dead. And should we take them off the ventilator, they will stop dying, and they will stop breathing, and they will die. So they've had a little bit of problems with that program recently, and I wouldn't go more into that. But the reason is that it's scarce. From those two situations, you can tell that's always be difficult. And this is not a problem unique to us. This is a problem that is happening worldwide. There's always a shortage of organs. There's far more patients than organs. And in Canada, for instance, where I worked, 7% of patients who are waiting for organs will die every year waiting for an organ, because there's just not enough. Which is where we come to, the latest thing with the pig kidney and stuff, which I didn't really want to get into, but which really is the future, to be honest.
I've read recent literature on that. I guess that's a topic for another day.
That before we continue, you spoke about the protein, where there'll be let's say a test showing up that there's too much protein, like in your urine and stuff. What kind of signal that sends for someone who is not diabetic?
Right. Well, that's it. Once you have protein in the urine above a certain level, and the level that you're supposed to have is quite low, then there's a problem with your kidney, whether you're diabetic or not. Now, remember, diabetes is not the only cause of kidney disease. There are many other causes of kidney disease. Yeah. So once you have protein in the urine, it says that you have kidney disease, 100%. Now, of course, just as there's a difference between 1 and a million, there's a difference in terms of how much protein. So the more protein you have is an indication that process is probably far more advanced or a worse process than if you have a little bit of protein. But the fact that you have protein in the urine means that your kidneys are already damaged. And this goes back to something that I say on these shows all the time, and I wish they could bottle it and just send it out to everybody in Trinidad and Tobago. The first sign of damage to the kidney is protein in the urine. The problem we have in Trinidad and Tobago with a lot of primary care doctors is there are two ways you assess kidney function. You assess with protein in the urine, or you can assess with a blood test called a creatinine. Many times they will do the creatinine, and the creatinine will be normal, okay? But they don't check the protein in the urine. But guess what? The protein in the urine is the earliest sign of disease. And especially if you have a lot of protein in the urine, your creatinine may be normal today, but it wouldn't be normal a few years from now. So a lot of times, patients have protein in urine that's missed. They just check the creatinine. They say, oh, your kidney good. Your kidney is not good. It's leaking protein. That's a sign of injury. It's also a prognostic sign. The higher the amount of protein means the kidney function is going to get worse. It's ignored or not picked up. And then a few years later, you turn up and everybody wants to know, oh, what has happened? Well, nothing has happened. It's that it was there from time zero. It was just not either picked up, not checked for, missed. And I cannot emphasize how much that patients should know this and insist that their urine is checked for protein. In fact, in my opinion, a urine dipstick test, which is a simple test, you pass a little urine sample, they just put a stick in it and they look for a color change, should be part of every medical consult, just like a blood pressure. Every time a patient goes to see a doctor, a blood pressure should be done. And in my opinion, every time a patient goes to see a doctor, a urine dipstick should be done.
Tell me, are there corrective measures that can reverse that situation?
Exactly, there are. And the earlier you institute those corrective measures, is the more likely we are to save your kidney and to stop progression of your disease or to reverse it. Mm-hmm. And that's the problem. The longer you wait, the opposite is true. The less likely it's going to respond and the more likely it's going to progress. And that's why it's so early to pick up these things why it's so important to pick up these things at an early stage.
Okay, thank you so much.
Urine dipstick testing. How accessible are these at every pharmacy? You can get those things regularly.
Yeah, you could go and buy urine dipstick. You could do it yourself. It's just literally passing some urine and put the stick in, leave it for about a minute or two, and then you compare the color on the bottle to the color that you have on your stick. And if there is blood or protein, the color changes. That's usually the things we look at. There are other things in it. You could check for glucose, you could check for the pH of the urine, you could check for bilirubin, all those things. Those are with regards to us, in terms of nephrologists, what we look at is the blood and the protein. Most times. We may look at the pH sometimes. And it's just a color change. You look at it and you can tell.
Tell me something. Where the urine color is concerned, would that tell you as how much protein is in the urine?
No, so urine color is usually a function of how concentrated the urine is. So if you drink a lot of water, your urine is going to be more amber, more straw colored. If you're dehydrated, you're conserving water, your urine is going to be a bit darker colored. However, one of the clues to having a lot of protein in the urine is that the urine is very foamy. That has been observed. So people with a lot of protein in the urine have frothy or foamy urine. They tend to say the urine is very frothy. Now, that doesn't mean because your urine is frothy means you have a lot of protein, but it is, if you have that, you should have it checked out because that is often a sign associated with a lot of protein in urine, frothy urine.
Oh, because I know I've heard the talk of your urine, once it's clear, it's okay.
That is absolutely untrue. Absolutely untrue. You can have very bad kidney disease and have clear looking urine. That's just a function of the concentrating ability. That's all it's a function of.
Okay. Fareed?
Well, you're teaching us something there. I always thought if it is your urine is very yellow, you're in trouble. And
no. In fact, if your urine is very yellow, it means your urine is concentrating very well. Because that means you're trying to conserve water. It means you should be drinking some more water. That's what it means. But it shows the urine is concentrating well.
Wow. And you mentioned earlier, I just want to backtrack just a bit. You mentioned earlier that you could have living donor transplants and deceased donor transplants. And,
yes.
If your brainstem is, if there's an issue with your brainstem, you can still harvest an organ from that individual, and we have legislation in place for that here.
Yes.
How difficult it is to what does one do to become a donor and to be on that list and to make your kidney available to, let us say, to someone who may need it down the road?
You go sign up. There's a National Organ Transplant Unit in Eric Williams, and you go and you sign up. And you will be down on as a donor should harm come your way. But more than that, and I always tell patients this, more than that, is you should express your wishes to your family. You should have that discussion. Because I'll tell you this, and even in Canada we did this. Even if you are on, and that's a where I worked, it's all electronic and you're in a database and all of that. But even let's say you have signed up and indicated that you would want your organs to be donated should you reach that stage, we always sought the permission of the next of kin. Always did. And of course, like 99% of times, they're going to say, well, that's what they wanted. I'm going to respect their wishes. So apart from just signing up, I would also say that you should express your wishes to your loved ones and say, hey, if I ever in a situation and so, and, the doctors are saying, I'm brain dead and they approach for donation, I would like you to sign the paper and give permission. And I think those are the sort of discussions that need to happen.
Perhaps there should be greater public education. I don't know if I missed that education.
Well, I agree with you. I completely agree with you.
I would imagine and all. I mean, and I'm being controversial here, right? I'm a lawyer. That's my day job. My thing is, if it is incentives are given to persons in prison who are serving a 30-year jail term, that they may get a reduction if it is they donate a kidney.
Well,
a man would do it,
You're going into the ethics of donation, which is one of my favorite topics, but is highly controversial. There is the Istanbul was it Accord, but it was a conference that took place in Istanbul many years ago, which guides the ethics behind donation of organs, and that certainly wouldn't fly with the Istanbul Convention, because and I mean, people could disagree with this. The tenets of donation is that it should be altruistic. Now, are we being naive to think that humans are all altruistic? I have my own thoughts on that, but the tenet and the thinking behind it is that donation should be altruistic, so it should not be incentivized. So even in Trinidad and Tobago, it is illegal by law to incentivize a donor. Now again, we could argue, well, what are incentives? There's money and there's kind. People could get incentives and kind, even within families. You may have a brother donating to a brother, but the father promising the brother who donate a piece of land somewhere down. So it becomes blurry. If people only think that, people think of money. Oh, well, you can't pay him to give you the kidney. But there are other ways that people may be able to incentivize donation, which by the letter of the law in Trinidad and Tobago is illegal, and which by the Istanbul, the tenets of the Istanbul Accord is discouraged and is illegal. In fact, there's only one country in the world where you can legally purchase a kidney, and that is Iran. It used to be Pakistan, but even they changed their laws. So anybody who you hear about going wherever to get a kidney from whomever, it's not being done legally.
The irony is the persons who are making that decision are the healthy persons. Because if you ask a man who needs a kidney, he's getting one from whatever source, he's prepared to take it.
Well, let's say, Fareed, you get into a discussion. I mean, I have my own thoughts on this matter, which will be controversial. But you're getting, and because I deal with these patients, I see them. I see their miserable lives on dialysis. I see them suffering, and I know that there's a solution out there for them, which is a transplant. And you see them just not being able to access that, and it's difficult. But these things have been vetted in the past in many first world societies, and we still believe in the human altruistic pathway rather than any form of incentivization.
I would imagine that's a discussion for another time.
That's that is certainly a discussion for another time.
I don't think we as human beings in the scheme of life are all altruistic. Every decision that is made.
I completely agree with you.
Yeah, there's a selfish part of each one of us that we make a decision, even in the choice of the life choices that we make, to please ourselves first, and then if it pleases others. That's
Correct.
A normal thing.
Let me see if I can get a question in here before you continue, Frida.
Yeah.
I'm very interested in this topic here today. Tell me something, Doc. You'll be normal during the day, but at night times you urinate a lot more. What does that tell you?
If that's a man, then that's probably a prostate issue, in that their prostate is beginning to become a bit enlarged. That's often a sign of an enlarged prostate.
Okay.
It could also be a sign of chronic kidney disease as well. That's what we call nocturia, where you just tend to pee more at night, and that is a sign that you may have some kidney disease. So it may be normal, and you just psychologically you're just passing urine more at night. But certainly, if it's becoming a problem with their quality of life, I think they need to check it out.
Okay. Thank you again.
We hear people talk about renal failure, where you're on a dialysis machine, you have to dialyze every, twice a week. We're talking diabetes. I believe when people understand what diabetes could lead to, they would be more mindful of controlling their habits and their lifestyle and their life patterns and so on. But the fear factor with you doctors is always there are serious consequences. You're already in that zone, in that area where the effects are taking its toll. What exactly is renal failure, and how does a diabetic patient get to that point where renal failure sets in?
Well, as I said, we don't really use the term renal failure. That's more a colloquial sort of street term. The scientific term we use is chronic kidney disease. And as I said, the reason for that is because that's the scientific term, and also chronic kidney disease is a broad spectrum. How do diabetics come to that? Well, the increase in blood sugars, what it does is it creates some abnormal glycated protein. So glucose goes and attaches itself to protein molecules that it shouldn't ordinarily do, and these go and deposit in the kidney. I don't want to go into the scientific terms as to what exactly happens. It also affects the blood flow and the blood supply to the kidney. So it increases the pressure within the filtering unit in the kidney. And as we say colloquially, pressure does bust pipe. So the increased pressure that is being transmitted to the kidney causes scarring and damage to the kidney. And once that continues over time, the scarring and damage becomes worse. And once the kidney is scarred, the tissue becomes non-functional. It doesn't work. It cannot perform its duties.
All right. What is your view? We have a lot of what we call in triad bush doctors, right? These people out there who they're telling the public that there's a herbal way of treating every condition, and come to them and they diagnosing, prognosing, treating, and so on. Is there any merit in non-pharmaceutical treatment, if I may put it that way? That's my language. In terms of accessing non-pharmaceutical drugs, or and
well, for what purpose? There's no evidence that any non-pharmaceutical drug affects chronic kidney disease, cures chronic kidney disease. Listen, if they had it, right? Let's say they had it, and I found out that there's this bush that if you drink it, your kidneys get better. You don't think somebody will bottle that and sell it for about $1 million and make a lot of money? I mean, that why would you hide that or it not be available? There's no conspiracy. There's nothing in fact, the opposite is true. The opposite is true. Because of advancement in pharmaceuticals, patients are living far longer than they used to in the past. So no, there's no evidence for any non-pharmaceutical, non-traditional remedy in terms of chronic kidney disease. So really a snake oil salesman. That's what it is. And playing on people's emotions, because when a lot of times these people are diagnosed with these things, they're desperate. So, I tell a patient, listen, your kidneys are gone, you need to start dialysis. They're desperate, they're shattered. They're looking for anything to hold on to. And that's what they play on. They play on some sort of false hope. And then when it doesn't work, they said, well, if you had come earlier, then, everything would have been okay. But it's not that. And I mean, I had so many patients who did this and ended up in a far worse state because they just delayed doing what they should have done long time before. In terms of kidney, if I could think of any, I don't even think of that as an alternative treatment, but the one natural remedy I know of in terms of kidney is lemon juice, for instance, is proven to reduce the incidence of kidney stones. So patients of mine who've had kidney stones, I tell them to drink some lemon juice without sugar. That's the one thing, and that's proven, that's been tested, it's gone through clinical trials, and we know why, because of what it contains. But that's the one thing that I would say is that the only sort of non-pharmacological treatment that I know of that is proven to work in any way. Cranberry juice works for recurrent, for infections like urinary infections as well, and that's probably the two things that within my field.
Dr. Lynch, you have a friend here, Kieran Yip Ngo. Am I pronouncing it right, or Ngo?
Yes. Yep. No.
Right. He's saying good afternoon, good evening, and he's saying that you can get kidneys on the black market. He's also replying to what we were talking here about lemon juice, and he's saying apple cider.
Apple cider vinegar, not really proven for kidney stones, but it's definitely has other health benefits in terms of suppressing appetite and stuff. I think it's fantastic, but in terms of kidney stones, there's no good evidence for it. And yes, maybe there are kidneys on the black market, as there is anything illegal. You could get anything illegal in this country. I never said it's not there. I'm saying it's illegal and it shouldn't be done. That's what I'm saying.
Yeah. Tell me something, Doc. You talk about pharmaceuticals. Of late, we've had a lot of fake stuff on the market and stuff. And how can one be guaranteed of the to get the prescription fulfilled, right? Or filled? You go to a pharmacy and you're not sitting. Now, if I go to a pharmacy to buy any pharmaceutical product, I always tell them I need the original.
Yes.
What happens to those who just buy it because, like you said before, the money factor will factor in, But yeah, so I don't want that.
You're like to get me in these controversial things. So, I mean, there's a difference between a non-registered product and a fake product. What we saw with the whole controversy of fake drugs is not a fake drug, it's just a non-registered drug. So the drug is a real drug, and it's a drug, but it hasn't come through the right channels to come in the country. That's different from a drug that is, you're taking a pill and is drywall or something in a pill, or sugar or something. Those are two different scenarios. So I don't think in Trinidad we actually have the latter, where we have a drug that is marketed as X and it actually has nothing in it. What we actually have is these drugs that are coming in via non-traditional means, I should say, but it's actually the product, and it's actually coming through Central America, where most of these drugs are actually manufactured. So the original product, a lot of these pharmaceutical companies, their manufacturing takes place either in Panama or Costa Rica, for our area. So the original drug is manufactured in Panama and Costa Rica. So what happens is people, through whatever links, they get their supply and they bring it in through other means rather than the correct ones.
Yeah.
That's more the situation that we have, rather than a drug that actually contains absolutely nothing that it says it does.
But the question I need you to answer a little more definite. In the pharmacy, right? So in the pharmacy, they have these two varies or variation of the same
right
product.
So they have the original and they have the generic.
Yes.
So technically, they are both supposed to be equally potent. Yeah.
Okay.
No, the question is do we check those drugs in Trinidad and Tobago? Right. So do we actually, or we take their word for it, what they say? Do we take a random sample from a generic, even from the original, and we put it through a mass spectrometer and say it contains X, Y, and Z? Or do we just accept what the manufacturer says it contains and we bring it in? And that's the important question. And people have questioned whether we're doing that. And I know at one point we weren't. I don't know if they've started back. I don't know. I honestly don't know. And that's sort of the issue.
Okay, so if like for me, I wouldn't look at cost. I want the original. So let's say someone buys the duplicate or the imitation of that same product. What kind of effects or side effects? What kind of?
I mean, that's an impossible question to answer, because it depends on, is the generic a good generic? Does it contains the, some brands of drugs have 10 different manufacturers. Right. So the popular ones, you'll go and you'll find 10 different manufacturers. So it's impossible for me to say, what are the side effects. Technically, the fact that they're on the shelf, they are supposed to be an exact replica of the parent product and not supposed to cause any deleterious effects.
Okay.
Technically.
Yes.
We all know we live in Trinidad.
I hear you, Doc. Thank you so much. Thank you.
How I've been sitting here whilst you're talking to David, trying to find the best way to couch the next question. In terms of the internationally acceptable best practices in treating with kidney-related issues, from a medical practitioner's point of view, where are we in Trinidad and Tobago in relation to that standard?
We have everything that we need in Trinidad and Tobago. I can tell you that with 100% certainty. Whether it's readily available in the public sector is a different issue. But I can tell you that we can do nearly everything here that could be done abroad. We have the expertise. We have fantastic doctors in this country who have been trained in fantastic institutions and have lots of skills, and we don't even recognize that. We have fantastic nursing staff, facilities. We can do everything in this country. I told somebody that the other day. In fact, just a patient today came down from the UK, came back from home, and he asked me if we have these drugs, and I had to laugh. I'm like, these are basic drugs. Of course we have this. You'll probably get it easier here than you'll get in the UK. So yes, we have what it takes.
Now, Our previous guest indicated to us that there is what we call a newborn screening for diabetes testing available, but it's not in the public sector, it's private sector, and I would imagine that that comes at a cost. Um, you just indicated that a lot of the treatment that is available, it is available. We are in tune or in line with internationally best practice standards, but it may not be available at the public sector level. Why is that so? Is it that we need more government intervention or government investment? Or is it that the need for it has not been emphasized enough, that the government or the state has taken it on board to ensure it's available to all citizens?
Well, it's not only available. Sometimes you have and then you don't have. So then you go, you get sometimes, and then you don't have for 2 months, and it's erratic. But the whole problem is the cost. I mean, healthcare is costly, and I don't think people appreciate this until they actually have to pay for it. You know, same thing with education. People go to school, you know, they pay nothing. They get taught, they do things. If they actually look at what is the cost to go to a private institution, a private school of the equivalent value, then we would really appreciate the true cost of this thing. It's very expensive, and the technology is getting better. The drugs are getting better. People are demanding more. You know, doctors are becoming more highly specialized. All these things, where it may improve the delivery of care, also increases the cost. And that's a major factor. The major factor is cost. A lot of these best drugs are not cheap. They're very expensive. And therefore, again, you have to take a longitudinal look at this. Do I invest in this now to reap reward in the future? Any preventative mechanism in healthcare takes at least 15 to 20 years to see the effect. Just remember, so 15 to 20 years. That's 3 to 4 government terms. All right? So people are in office to do X. They probably don't want to say, well, in 20 years, you all will see people, you know. So you get politics with cost. And it's a whole kind of deluge, and that's part of the problem, that we need to have a unifying vision, no matter who in government, whatever, that this is the path where we're going to go, and we're not going to deviate from this, because we are looking at this thing 20, 25 years in the future. But if every time things change and this change and that change and we change this and that, then we're never going to reach there. And that's part of the problem.
Mm-hmm.
Is this sort of dialogue a dialogue that the medical board or doctors like yourself have with the people who make the decisions in this country, health-wise?
Well, one, that's not that's not the remit of the medical board. The remit of the medical board is to license and to license and to overlook the practice of physicians. Their policy with regards to healthcare is not their remit. So I mean, that's really not their medical. So that's a medical board. Now there's a medical association, Trinidad and Tobago Medical Association.
Yeah.
That will reform part of their remit. But these are not discussions that haven't been had. Over the years, these are not discussions that haven't been had.
Wow.
How many? We had was it Gladys Gaffur, who had a commission of inquiry into health. We had Winston Welch the other day did a Welch report. We keep doing these things, and what comes out of it? You know?
It's interesting that that comment is being made at this level as it relates to health. And it's the same parallel comment made in so many different areas. So
of course,
that we're misfiring in many, multi-sectorally we're misfiring here. in Trinidad and Tobago.
Yeah.
Doc, you spoke about kidney transplant and stuff. Diabetics, they have a problem when they get external cuts and stuff, right?
Yeah.
You get a cut on your foot, it could be infected. What's the comparison with surgical removal with a diabetic or someone who is diabetic and needs to do like a kidney transplant? Surgery, like
Well, guess what? The number one cause of kidney disease worldwide and in Trinidad and Tobago is diabetes.
hmm,
So the patients who get transplants most often are diabetics because they are by far and large the largest group of patients on dialysis.
mhm,
So just as we don't take a donor who just decide because they come and say they want to donate, it's
mhm.
the same way a recipient or a potential recipient goes through a screening process.
Okay.
So, patients, the people who get kidney transplants are the ones who are in the best shape. And invariably they wouldn't have those sort of problems most times. So there's a screening for both recipient and donor because you want to ensure that the person who is receiving this gift, this vital organ,
Mhm.
is going to do well and live long enough that it's of value. You don't want to give a patient a kidney and 2 weeks later they die of a heart attack. That was a waste of a kidney.
Yes.
So we send them through various rigorous testing, make sure their heart is okay, the diabetes well controlled, all these sort of things before they will be eligible to receive that kidney. So they don't tend to run into those problems.
Okay. Okay. Thank you.
Perhaps you could share with us some of your some of the some information about the stages of kidney disease. Naturally, before there is, you know, death as a result of chronic kidney disease, one would have experienced various levels of changes and problems.
Yes.
Could you walk us through what may be the initial stages and progressively what direction it flows?
All right. So based on your something we call the GFR, which is essentially how well the kidney excretes waste products. As I said, you could think of it as a percentage, but it's not quite. So we have stage one, stage two. Stage one and stage two really is where your GFR, a normal GFR is about 90 to 120 mils. Okay. And that's why I say you could think of it as a percentage because you could think of 100 as kind of almost cutting it down the middle. So you excrete 100 mils per minute of waste product through the kidney. That's a normal GFR. So if you have a GFR that's slightly below that, especially if you have blood or protein in the urine or your kidney size is a bit decreased, then we would say you have stage one and stage two chronic kidney disease. But we really consider the real thing starting at stage three. Stage three is when you're less than 60 mils of GFR. And stage three is divided into A and B. So you go from 60 down to 45 will be A, and 45 down to 30 will be B. So you'll be stage 3A, stage 3B. At 30 down to 15, you'll be stage 4, and below 15, you will be stage 5, or that's the last stage, below 15 mils of GFR, below 15% kidney function. And we stage it based on that, based on the GFR. How do we get the GFR? We do a test called a creatinine, okay? And based on that test, we put it into a fancy formula which takes other factors into consideration, such as your age, your sex, and age. Well, it used to be race, but that has been taken out of the equation in recent years. So age, sex, and creatinine, we put it into this formula, and it will, everybody have it on their smartphones. Nobody knows the formula. It's a big fancy formula, and it will spit out a number, and that is the GFR. Most labs now would automatically report it once you do a creatinine. And in fact, in places in America, it's mandated. So once a patient goes and they do a creatinine, whatever that value the creatinine is automatically goes into the formula and is printed on the report from the lab.
Wow. Is it recommended that, is there a particular age, or is there, it's nothing to do with age, where we ought to be doing creatinine testing?
Yeah, 100%. So certainly at any age, once you have hypertension, diabetes, at any age. So if you're 20 and you're diabetic or hypertensive, you should be checking your creatinine every year, along with your urine protein. Okay? Depending on what the value is, you may need to do it more often. What is recommended is if you have a family history, of kidney disease, you should probably start screening yourself from around 40. Everyone else above the age of 50. So if nothing wrong with you, as far as you know, you're not hypertensive, you're not diabetic, you don't have a family history, as far as you know, you're healthy, then above the age of 50, once yearly is recommended.
Normally, doctors tell you do your blood work, and then they work from the blood work. You're saying this, you may be doing blood work, but you should also do that creatinine test.
No, the creatinine test is a blood test.
Okay.
It's part of the blood work. It's a blood test.
All right.
So when you go for like blood work, as we call it,
yes,
you get results that will tell you about what's happening in the entire body, all the organs, or?
Well, it depends on what blood work you do. I mean, the list of different blood tests is exhaustive. So you could have blood tests that look at your kidneys, at your liver, at your thyroid, at your other endocrine organs. So it depends. So nobody just does you have tumor markers, for instance, for cancer. So we do the test as appropriate. In other words, if you present with certain symptoms, you do that test. No, there are certain tests that's sort of like standard. One of them is a kidney function test, or you may call it a renal function test, and it contains creatinine and electrolytes, so your sodium, your potassium, your chloride, those things, right? So that is and also like a blood count. You'll hear people talk about a blood count. That's a standard test that is always run for everybody. But we wouldn't do a full endocrine profile in an otherwise, healthy patient.
Yeah.
So it depends.
Okay. Fareed.
With kidney function, and you mentioned the figures there, in terms of stage 1, 2, and 3. If we, and when I say we, if the lay person out there is listening, is any of those, or are we in a position to treat with a condition at any stage and reverse the condition? Or once you begin that descent, then it's a question of managing it to the next level?
So there's no therapy that has been proven to reverse chronic kidney disease, but there's certainly very good drugs that help to reduce the rate of decline and stabilize it. So in other words, I tell people, if your GFR is 45 today, you will not be sick. You will feel well. But if we don't institute measures to ensure it doesn't get any worse, then you're going to be in some trouble in years to come. So the best drugs, what they do is they stabilize the kidney function. So the rate of loss is very slow. There's natural rate of loss. So as we get older, we lose kidney function. That's just aging. But above that, it's very slow. So what it will tend to do is stabilize your kidney function to ensure that you don't reach the stage where you need dialysis. No, of course, that depends. If it's really bad, it may slow it down a bit, but may not stop it and prevent it. But the whole point is that the data all shows that the best time to start is at the earliest time. So the later in the game that you are instituting these measures, is the less likely that it's going to work and the less likely that you're going to respond. It's always better when it's done earlier. Which brings up the question of screening and picking up disease at an earlier stage.
Well, You know what you're saying, it speaks volumes. I guess screening is very important. You have to keep screening. It's where we started. If you have a car, you need to upkeep the car, and you need to have it tuned up and from time to time. So I guess screening should never stop throughout one's lifestyle.
Correct.
You keep
No,
screening.
correct.
Apart from the checking the protein levels in your urine, is there any other way of checking signs and symptoms?
Well, that's the thing. Most times you have no signs or symptoms. So, so once you start to reach to the later stages, some of the symptoms are fatigue. So you tend to get tired, and that's because your blood count goes very low. All right. Because remember, I said one of the functions of the kidney is to make a hormone to increase your blood count. So when the kidney isn't working, the blood count tends to go low. So people get anemic, they get tired. Oftentimes they ignore that. They're under stress. We tend to ignore. So they tend to get tired. Again, with kidney disease, because it's responsible for salt and water excretion, if it's not working well, you may get swollen ankles. So you find that your ankles are swollen. We call that edema. That could happen even at an earlier stage, depending on if you have a lot of protein in the urine. But certainly at a later stage, that tends to happen. You tend to retain salt and water because the kidney isn't getting rid of it well enough. You tend to become very nauseated. You have no appetite. Every time you smell, people will tell you this: when I smell meat, I'm feeling sick. And then even at a later stage, you tend to be vomiting all the time. Then you really start to feel unwell at that stage when you're vomiting all the time, or you can't concentrate. Those are when you start to get to the later stages of chronic kidney disease and some of the symptoms you may have.
How do anemic individuals do establish that balance in terms of, I know we're talking diabetes, but at the same time, we may have anemic people out there. Does anemia worsen one's ability or makes it more strenuous for a diabetic person to manage the condition before it gets to that?
Well, yes, if anemia is severe enough, it's going to start putting stress on the heart. But I mean, for the general person out there, the question is, why are you anemic? Kidney disease is one cause of anemia, but there are many other causes as to why someone could become anemic. So the first thing is to find out the cause and to address the cause. So if you're anemic, I often hear patients and they say, "Doc, I'm anemic." And I say, "Okay, why?" "Oh, I've been anemic a long time." Well, no, there must be a reason why you're anemic, right? So the first thing is to find out the cause. You should investigate most cases of it. Some are pretty obvious, like young women may have heavy menses, heavy menstruation, so they become anemic because of loss of blood. But there are other cases, once you have anemia, you need to investigate why. And I'm talking outside of people with kidney disease, because the vast majority of people with kidney disease who have anemia, it's because of their kidney disease. But we could correct it. So the hormone that your kidney normally makes, it's available in the form of an injection. So we make it in a lab and it's available in the form of an injection. So patients take those injections and they're able to get their blood counts up.
Is that available in the public hospital?
Very much so.
Okay.
And it's actually quite an expensive drug and it's readily available, I must say. I'm very impressed that we always have supply.
How difficult is it to manage kidney disease generally in terms of I get you in terms of the screening, I get you in terms of diet and so on. What would be the advice from your point of view, from where you stand as a specialist, as we say, in terms of a person who has a kidney dysfunction or chronic kidney disease? I'm using your language. In terms of managing that, what would be some of the advice or some advice?
Well, first thing is sodium restriction. So you got to get the salt out of the diet. It's got to go. No salt. Get rid of it. The salt promotes water retention. The salt promotes high blood pressure. 2, blood pressure control. Very, very important. have to control the blood pressure because having a high blood pressure puts further damage on the kidney. 3, control of your diabetes. If you don't control the cause of the problem in the first place, it's just going to get worse over time. 4, take your medications. And this is a very important one because lots of people don't take their medications, or they miss medications, or they skip doses, or, you know. So those are sort of the things that really need to be harped upon. And the other thing is really psychosocial, where is acceptance of your diagnosis. And this is very difficult for some people, where they don't really accept that anything is wrong with them. And until that acceptance could take place, then they can't really heal. They can't really move forward. They're still in a denial sort of phase. But that's really, as I tell people, for me, medicine is not difficult. Nephrology even less so. I've done it. I've seen it. I've done it a long time. I worked trained in a really good institution. I've seen everything. Far more difficult is the interpersonal reaction. Is how do I get this person to buy into what I'm telling them? Diagnosing what's wrong with them is not the issue. Getting buy-in and getting them on board is often the most difficult part of medicine, that interpersonal relationship. Is this the man who I could tell, sir, this is bad? Or is this the man who I have to sort of finesse it in slowly? Because he can't handle that situation. And oftentimes that person comes in your door and you have about 5 minutes before you have to make that decision on what you're going to do. And that's where the difficult part of medicine comes in.
Tell me something, Doc. Well, you spoke. Marlon Rampersad is also questioning some of the things. I guess you know these guys. What are some of the things one can do to avoid kidney issues? Well, I guess what you just said there, preventative food, it just aligns with that question. What I want to ask is that, okay, so protein was seen in the urine and stuff. Is that corrective? Could you correct that? Could you?
Yes, it can be. We have very good drugs that can reverse proteinuria. But again, the first question is why? Mm-hmm. And the second question is how much? Mm-hmm. So, for instance, you're allowed about 30 milligrams of a protein called albumin in the urine. Yeah. If you have 120, we don't lose any sleep over that. Mm-hmm. If you have 5,250, we lose plenty sleep over that. So the first thing is a dipstick is with the color change is a screening test. It's to say protein, no protein, but then after that you have to do a test to measure the exact amount. Yeah. And when you measure the exact amount, then that amount is important. And then is what's the cause? Now, if you have diabetes and you have protein in your urine, the natural assumption is that it's because of the diabetes. Yeah. And that's true for about 95% of times.
And if you don't,
but as I said, there are other disease processes that affect the kidney that cause protein in the urine that are not diabetes. And sometimes, if we don't have a good explanation, then we may need to do something called a kidney biopsy, where we actually take a little piece of the kidney out and we look at it under the microscope so that we can see what is the injury pattern that's affecting the kidney.
Can ultrasound assist in seeing what's wrong with the kidney?
No. All ultrasound could do is tell you about size, location. If you have two, sometimes people are born with one kidney, as I said. And also if the system is flowing well, if there's no blockages in the system. It can't diagnose what's the cause of anything.
It can see particles in the kidney.
No. Can't. No way.
Okay. I'm asking all these questions because I'm always very concerned about kidneys. If it's one organ, I'm always concerned about his kidneys and the prostate.
Me too.
Yeah. And I think, men in particular, like Kieran is saying, men hate to go see doctors.
Yes, they do. We have a huge problem in this country with men. I'm telling you that men not only hate to go see doctors, they're very much not accepting of diagnoses. I see young men, unfortunately, who are on dialysis. They have the hardest time coping. They are angry. they always, on edge, and it's just because they don't have the mechanism to cope. I think we still have this kind of macho society, and it's like, I'm supposed to be a man. Look where I am, and I'm on a machine, and we have it's a very difficult problem, and I think, I mean, in my younger days, I would say, not a dowel, I would say that I didn't recognize as much sort of the psychosocial nature. You learn medicine, they teach you medicine, they teach you how to diagnose, you do your thing. But with experience, you start to learn, hey, listen, these are people who led different lives before this diagnosis, and it's really difficult for them to sort of accept sometimes what's going on, and they really do need that help and that support.
Yes.
Yeah.
Kieran is saying they need a good wife. He said, my wife pull my ears and take me to take a blood test. Well, I too I have taken it very seriously. At one time, I remember the Cancer Society came to the station here and offered free blood testing for prostate and thing. And men, when it comes to prostate testing, so I was in that zone, and I said, not me. I ain't going to do that. And then I thought about it seriously, and then I went. So I make it a point of duty to do it every year.
Yeah.
And as we get older, it gets enlarged to an extent based on your age and stuff. So
correct.
What advice can you give to men? I mean, we're talking kidneys here, but I just need this to be a part of it. To digress a little bit, what should we? How should our mindset be, knowing that it's growing and it can be controlled and stuff? What kind of mindset? What would you advise men? Like if this.
Well, yeah, a lot of the problems with prostate and having enlarged prostate is genetically determined, and it's very much so amongst patients of what I call recent African descent, of which we have quite a significant amount in our population. Yeah. It's far more common amongst people like that. Unfortunately, the thing is really to monitor your symptoms. Yeah. And as I said, if you starting to find the slowing of the stream of the urine, you're not, as we used to say, hitting the wall as hard as you used to, or hitting the bowl as hard as you used to. Yeah. You find you're dribbling, you're a little bit of urine coming out, or you're going frequently, as I spoke before, to the bathroom, and that's because you're not emptying the bladder properly because of the enlarged prostate. Then those are signs of an enlarged prostate, and really and truly, there are good medications that could help to dilate up the tract. And then there's surgical procedures that you may have to undergo once it passes a certain point. But once you start to experience those symptoms, I would encourage people to go see their urologist and to get it checked out.
Okay, thank you again, Fareed.
I remember after I left school, after A-levels, not too long after that, a classmate in his early 20s was diagnosed with issues with his kidneys. I understand it evolved to the point where he had a transplant. And but when we met over the years and we chat, he would say that he can't play contact sport. He has to be careful if it is, impact.
Yeah, I mean, no, that's not true. That's not true. Absolutely untrue. I don't know why somebody will say that. So we don't put the kidney back in the same place that your native kidneys are. We put it just at the front of the belly, below the skin. All right. So yeah, I mean, I wouldn't advise you to play American football or rugby, but there's no reason that I wouldn't say somebody can't play soccer or football, like soccer or tennis or swim. There's absolutely no reason they can't do that. That's not true. So I mean, the concern is that it's now superficial. It's more superficial, so that if you get trauma there, you can cause injury. So yeah, for sure, I wouldn't tell you go play rugby and be a linebacker in American football, but certainly, most sports you can still play. Swimming, for sure, there's no reason you can't swim. I don't know where somebody would get that information. That's absolutely wrong.
But that's good to hear. I had inquired from him, what about swimming is the issue, because I swim a lot, and he was saying that the water contains bacteria, and it
Yeah,
also
so the water doesn't contain bacteria. That's why they put chlorine in the water. That's the first thing. And number two, I'm assuming this would have been a very long time ago that he was transplanted. And a lot of the practices that they did then, we realized all right, for instance, when I trained in Toronto, the average day of discharge after a kidney transplant was 3. We sent patients home in 3 days after a kidney transplant. Imagine that. Long ago, they would keep patients in the hospital for a month. Okay, a month. So a lot of they would put them in this room and treat them as though they're like bubble boy and you can't touch them. And a lot of those practices were based on the fact that at that point in time we didn't know what we know now. And I'm certain in 20 years the doctors there is gonna look back at me practicing and laugh and say what Lynch and them was doing. Because as you get more knowledge and technology gets better, you do things better. So maybe that was done then because out of ignorance and people just didn't know, but that's certainly not practice now. And practice now is far more advanced, and we don't need to do things like that. We aim to get people back to their regular lifestyle. We aim to get you back to doing what you used to do before you were on dialysis. We want you to live well. We want you to have your dog. We want you to have a pet. We want you to interact with people, because that's human nature and that's what humans were meant to do. So this sort of restrictive sort of thing that was done many years ago, we don't do, because we realize we can not do it safely, even though you have a transplant and you're on immunosuppressive drugs.
Well, I think we've covered a lot of material. One of my concerns through the programs that we've done in the past is I'm trying to create greater awareness through consequence, if I may put it that way. When persons know and persons learn that mismanaged diabetes or mismanaged practices and lifestyle habits can lead to certain consequences. In this case, we're talking kidney disease. Then, mindful of what the price you would have to pay down the road, people may be incentivized into making changes in terms of how they
well, part of the problem is, as I said, the first thing is people have to understand how bad it is to have diabetes. I don't think people understand that. People think, I have a little sugar. It's not little. It's bad. Having diabetes is bad. And I always give an example. Many years ago when I was in training in Canada, that one of the infectious disease doctors said that if he had a choice, he would have preferred to have HIV than diabetes. You may laugh. HIV in the first world with the best medications is like having high blood pressure. You take your medication, how long Magic Johnson living now? Right? You take your medication, you suppress the virus. These people have no viral loads. They live in completely normal lifestyles, right? We transplant patients with HIV, by the way, as well, right? But diabetes, heart disease, kidney disease, eye disease, loss of limbs, nerve pain, right? Diabetes is a horrible disease. But people don't see it that way because they think, I'll have a little sugar, take my little tablet. Now, guess what? Yes, you have a lot of people who have absolutely no complications. But there's a lot more who have. And there's a lot who have no complications at this point in time. What's going to happen in 5-10 years? So until people start to see diabetes for the beast that it is a beast, it is bad, then we're going to be kind of spinning top in mud. People have to recognize how bad it is. The first thing is to prevent it by embarking on healthier measures. The second thing is, if diagnosed, to take steps to ensure that you treat it with urgency and that you treat it well and you get it under control. But it's the first thing is the realization of how bad diabetes is. Far less having diabetes and being on dialysis. Having diabetes and being on dialysis is in a lot of cases worse than having cancer. But when I tell you have cancer, everybody cry, oh God, one day, oh my goodness. But if I tell a diabetic, your kidneys are bad, you have to go on dialysis, they don't see it as equivalent. But in many times, it's even worse. Diabetes is very bad. We need to recognize that. We need to preach it as that. And then we need to take stock of it.
I always say it's the spawn and ground for a lot of different diseases.
It is.
Yeah.
We have a drinking culture in this country. Everybody loves to drink. And do you see a relationship in your practice between people with kidney problems and having a lifestyle of alcohol consumption? Is there a correlationship?
There's not a direct correlation, but there's certainly a correlation between alcohol consumption and the development of diabetes. And then there's a correlation, obviously, between diabetes and kidney disease. So invariably, while it may not be direct, it certainly is going through the path of the diabetes, because certainly alcohol consumption is highly associated with worsening chance of diabetes and poorly controlled diabetes.
But alcohol in itself it's made from sugar cane, so it's a concentrated sort of thing. I know about that. Before you we're coming so close to the end now. Kieran wants to know, where are you based and how do you book an appointment? And he wants to apply with his Pressman credit card, seeking a discount. I know these are your friends texting here. Messaging.
Yeah. Kieran and I went to school at Presentation College San Fernando together. Him and I always bantering on Facebook as well. So he giving me a good few right now. That's what's going on.
I want to know also, what's the use of a hot beer?
I have no scientific proof of any benefit of a hot beer. That being said, the amount of people tell me they had a kidney stone and they drink a hot beer and they pass it, I cannot ignore so many people telling me that, assuming it's true. But I have no scientific evidence myself that a hot beer is of any benefit. But lots of people say that, though. Lots of people claim that.
Yeah, even Marlon is saying that. So why is you not shouting we out? So I'm just responding to these comical messages, see that we are at the end of the program. These guys have been laughing in the studio here. So I guess these are your schoolmates and stuff,
Yeah, these are some guys I banter on Facebook with as well.
Oh, okay.
People often say that when you drink high quality liquor, high end liquor, as we say in Trinidad,
premium.
That is less
No, that's not true. That's them. They making themselves feel better for some reason.
They even made that calypso like that. When they drink, they don't get sick. But I think this was highly educational. I was really happy that Farid brought you on. I asked you a lot of those questions because I have friends who have problems like that, and we always try to discuss it. I try to make them understand that you need to have a medical checkup at least once a year.
Yeah,
find what's happening.
Completely agree. I couldn't agree more.
Yes. Farid?
We want to thank you for the time that you've spent with us and making yourself available. I mean, you've been really helpful in terms of the information you've communicated, and you've communicated so well. Sometimes doctors talk over our heads. You go to a doctor's office, and they're very quiet. It's very, very silent.
Trust me, I'm not that type of doctor. Farid, if you ever meet me, you'll realize I'm not that type of doctor.
Well, like Kieran wants to know. I mean, other people I know would probably like to know where you're based to seek advice and medical help.
So my public practice is at Eric Williams. My private practice is in St. Augustine Private Hospital. And if they want my contact number for the office is 373-7263.
Repeat that number for me again.
373-7263.
Okay. Thank you so much, Dr. Lynch.
No problem. My pleasure.
Dr. Lynch, we trust that we've established a certain amount of confidence between yourself and the network here now. And if we invite you again, you'd say yes and come again.
I have never once not accepted any invitation to increase social awareness. Never once. I believe that's part of my duty as a physician, that we need to spread the word and we need to get public awareness. And I see it, every day. As I say, we're getting worse. When I think we can't get worse with kidney disease, we're getting worse. And we need to have that public educational campaign in order to stem the tide.
Great.
Thank you so much again. Thank you so much again. And we look forward to another occasion. Enjoy the rest of the evening and be safe. Thank you.
Thank you.
Thank you so very much, Doctor. Yes. Thank you, Fareed. It's been a pleasure.
Same here. Enjoy the rest of the evening to the public, and David, be safe on your way home.
Thank you so much. These guys that said these are real curriculum messages. They cover them on your Facebook and they will repeat them. It's been a pleasure chatting with you today.
Take care.
Okay. Thank you for
Thanks again. Take care. Cool.
Yeah, that's it for today's edition of Hard Talk. We've had a very special guest, Dr. Sean Lynch, and we dealt with the disorders of kidney with diabetes and the disorder of your kidneys and stuff. So come tomorrow, we'll have another edition of Hard Talk right here at Power 102 Digital.
The future of talk is here.